Start your recording there. And you're back to where you are.
All right.
So much. Get started again at the second half.
No. Hey guys.
All right. So we're moving into our basic airway management. We've talked about positioning for about the 14th time. So let's go on to foreign body obstruction. What are we going to do there? So airway obstructions from foreign bodies, those are high risk for my kids because they put everything in their mouth, like I mentioned earlier. So they can be mild or they can be severe. If they look good and they're oxygenating and not working too hard, get them in their position of comfort and just get them to me. You can put a mask on if they're tolerating it. If they're freaking out because what is this plastic thing you just attached to my face and it's making things worse, take it off, put some blow by nearby, but just get them to me. If they're having severe signs of obstruction, they're in distress, that's when you're going to intervene. So big kids, abdominal thrusts, little kids, back blows, all right? And we've all gone through BLS, so you kind of know both the alert choking victim and the unconscious choking victim. Don't try and Heimlich somebody that's unconscious. You're going to kill your back. Put them on the ground and do abdominal thrusts. Yes, sir?
Do like the 5 thrusts, 5 arm throws type deal.
Yeah, so absolutely. That's all right. When you get a new job, it won't be a while anymore. Yeah, we're gonna get there for those that are looking ahead. Infants, 5 back blows and 5 chest thrusts. With them, if you see something in their mouth, sweep it out. If you don't see anything, don't blindly sweep. Remember that tongue is big and it may be obscuring things, but you may blindly sweep and catch the top of it and force it further and make yourself have a whole lot more problems. So if you see it, you can grab it. If not, keep your finger out. All right, so here we are. This kid's choking, he's not happy, so the first thing we're doing is we're looking at him. The medic there, who I don't know where they found their goggles, but okay. They came from chemistry class straight to work, maybe. Okay, so looking in that mouth, seeing can I see something and scooping it out if they can. Taking a look at how they're doing. Are they having trouble with breathing? Are they having trouble with their cry? Is it really like a breathy cry that they can't get anything up and out because there's something obstructing down below? Listening to their cough. If they're looking like they're coughing but nothing's really happening, there's probably an occlusion that's not letting that air flow out. So back blows, head down, grab that baby along the neck and chest with one hand, 5, flip them over and give them the thrusts. Then check their mouth, look and see what you can. If they become unresponsive, move on to CPR. Okay, bigger kids, you can't really do that. You can't pick a 13-year-old up on your forearm unless you're Hulk, and I don't see anybody that is, but maybe. Go ahead and do your abdominal thrusts with them. All right. Other basic airway management things you can do that are really important. Suctioning. Remember our little ones, they're obligate nose breathers. So if they're in distress and they're blowing bubbles, that's going to make it a whole lot easier for you to get that stuff out of the way. Use what you have. A bulb syringe fits in there really well. With bulbs, remember, this is what parents get wrong all the time. If you put it in the nose this way, it gets in there easy. The nostril fits that way for the tip of that bulb syringe. But you're cleaning this much of your nose. That little anterior triangle is probably not the problem. It's all the mucus straight back. So in and tip towards their ear to get the stuff that's back towards their sinus in the actual airway that's being a problem. A flexible tip catheter, a rigid tip catheter, depending on your child's size, can be used. The smaller you are, the more flexible you need to be to get into their nair and get some mechanical suction. Make sure that we're not doing more harm than good. So if your suction device is one that you can change the pressure on, you want less than 100 millimeters of mercury when you're suctioning interiorly in a child. Also remember, they don't have the same reserves. So that really, really, really juicy bronchiolytic that you can just hear there's more in there, you can't just leave the catheter there long term. They do need a break in between. So we do that. We, do one there, do the other, give the kid a couple breaths to catch up and then go again rather than just leaving it for one long suction. And then monitoring their pulse is important if you're doing anything deep suctioning wise, because you may vagal this kid with your suction catheter. So watch their pulse. If it drops out, be prepared to act if it doesn't rebound pretty quickly. And if their pulse drops, stop the suction. All right, oxygenation, that's the thing that we want to have as best as possible. We want really good numbers because they need more oxygen, they have increased metabolic demand, they have decreased reserves. So we're using that as our gold standard for when we need to intervene. With the pulse ox, what number do we need to have oxygen added at? 94%. So if we're getting low, then we need to go ahead and start supplementing them. Blow-by techniques can be used with kids. There's a variety of different ways to create blow-by. If you have a hard plastic ambu bag, can you lay the mask side of it on the patient's face and get blow-by? No, the reserve tube on the back is where passive oxygen flows, so turn it around the way you wouldn't use it. If you have the rubbery anesthesia bags that are more the balloon that inflate, those do flow oxygen out of the mask in, so you can use that for blow-by. We oftentimes will use the T-piece on the neb hookups, tape off the back end and blow out of that to make our blow-by. So if you've got nothing on your tube or truck other than tubing, you can even just leave an open-end oxygen tube blowing by their face if you need to. Getting it there is better than nothing. All right, remember that you need pediatric-sized things. So taking the adult non-rebreather that fits my face and smacking it on a toddler is probably going to be oxygenating their forehead and around the sides of their face and through their chin. You're going to lose a lot of your oxygen to the outside world, so fitting their face is important. If you can, demonstrate on yourself. Kids are going to be fearful of this thing going in their face and they don't really understand. So using that non-rebreather to give us the high concentration oxygen that your patient may need may also be very terrifying. So as this guy's showing, just hold it up. It's just going to sit right there. This little girl looks scared. It's got her in mom's lap. So mom's helping to give some reassurance. You may have to start with it just in front and then slowly make contact before you flip the band around. And I've even had to have moms who are or the spare hands in the back just holding it there because they're too freaked out by the rubber band going around their head. All right, so oropharyngeal airways are an option only if there's not a gag reflex. If you're trying to put an oral airway in and their gag is intact, they will choke on it and spit it back out at you. You're going to use a tongue blade if you've got it. Push the tongue out, down and out of your way, because remember it's big, it's going to occupy a lot of space. The curved end is going to be positioned downward. As you push down, slide it over and into place. The nasopharyngeal airways are also an option. Again, if you have a kid that needs prolonged ventilation, you're not at intubation, you think you can get by with a mask, but it's not quite enough, you can put this in the kid with a gag reflex, so it's not going to hit the back of their pharynx and make them cough it out. They may not like it as much, but still, it's a good thing to give a try too. Make sure you're lubing that up so you're not doing a lot of trauma as you're sticking in. Make sure you're lubing the external portion of the tube. Don't put a big gob down at the far end of it because you may seat it perfectly, but if you've got a ton of lube on the open end, you're going to just blow to that and not going to be as helpful. Make sure that you're sizing these. So hold the tube options that you have up to the side of the kid. If it's going to be one that's adult length and it's going to come from their nair way down to here, it's probably going to curl into their mouth, and so it's just going to be an outflow tract for you. So you want to make sure that you're appropriately sizing it for the patient that you're trying to put in. And if you have a kid that has mid-face trauma, so they've got an obviously broken nose, they've got bruising all over their mid-face, don't try and put one in. All right, with bagging, we want to make sure that we're using the right amount of pressure. You want to use enough force to make the chest rise. If you are emptying your ambu bag with every breath, you're going to breath stack that kid. We're all going to do that so you learn not to do it. All right, so everybody, just let me know when you get uncomfortable. Big breath all the way in. Blow half of it out. Big breath all the way in. Blow half of it out. Big breath all the way in. Up. Yeah, it didn't take long, right? So with bagging, you've got to be really careful about what you're doing. So if you're forcing bigger volumes into the balloon are pliable. They'll take that air, but you might not give them enough time to exhale. You're going to be doing damage as you're putting a lot of forceful air in there. So you just want nice, gentle chest rise. You also want chest recoil, because if you are appropriately bagging a normal volume and having great chest rise and letting it fall halfway and doing it again, you're going to do the same thing. You're going to breath stack that patient. All right. We've kind of gone over the rest of that. All right. Like I said, a mask that fits goes over the bridge of the nose and along the chin. So ventilation, we talked about chest rise is important. With making sure you can let a full recoil with them. And then if you haven't bagged a kid in a while, make sure you occasionally hop into the skills lab and practice that, because even though the dummies aren't perfect, they do have more of that flattened mid-face like a kid does. And so you just want to make sure you're keeping your skills up. And can I get a good seal on a pediatric patient so that when you need to do it, it's still there. With the adults, that's muscle memory for you guys. You do that regularly enough that you can just grab a bag, fit it, and pull a jaw up. It's just a little bit different mechanics in your hand for a kid. All right. In Spokane County, CPAP is not approved for pediatric populations yet. That is potentially a way, I haven't heard any talk of that changing here, but across the country, that's a wave that is starting to change. So that may be in the course of your career something that becomes available. And then make sure that you're not using the bag bath.
Well, younger or
My understanding is pediatric, so 18, but confirm with the gentleman in charge, because they're closer to the policies than I am. And then bag valve masks. You don't want to use the pop-off valves if you can help it. If it's all you have, it's all you have. But those get easily occluded and can be a problem. All right. So cricoid pressure. If you've got extra hands, you can make your bagging easier. The same cricoid pressure that's applied when you're intubating a patient can be applied to help you bag them a little bit easier. You're pushing that airway down into a more straight line with where the bag is. It also, if that patient starts to vomit, can be used to help occlude the esophagus a little bit. All right. When we're moving on to intubation, that same cricoid pressure can be useful in bringing that airway to where you need it to be to see. And for the 14th time, don't hyperextend the neck. It's just as bad as hyperflexion. All right, so how are we doing cricoid pressure? We're taking 2 fingers. We're finding that cricoid cartilage. That's that. If you're coming from the chin down, that's that first really prominent structure there. Putting a finger on either side of it and just pushing posteriorly. Basically, we're pinching the things behind it. The tracheal ridges will keep nice and open, but that flexible soft esophagus will collapse. That helps us out, 1, to get airway in line, and 2, to bring what you need to see into view if you're intubating. Because in kids, their airways are very anterior. It's more anterior than what you're used to with an adult. And so using that cricoid pressure may bring it down into view, make it easier for you. All right. So ALS procedures, that's going to be for those that are certified. So your paramedics, you guys are going to be moving all into these sort of things. And then you're going to go beyond things that you're doing just in a BLS setting. Sorry, this slide wasn't in my initial copy, so I'm just going to see if there's anything. Again, we're not, for foreign body, there's the middle one, there's an option for you. If the kid's unconscious and you want to get a better look and see maybe where that foreign body is, you can use your laryngoscope blade to sort of pull things up out of the way and look. If you have McGill forceps on board, you can use that to reach into the posterior pharynx and pull things. All right, and there it is. So McGills are a wider set of forceps. They're long, and they give you a good grasp, so you can visualize and reach down deeper to hang on to things. If you can't grab an airway foreign body, try and intubate around it, okay? And you're gonna need a smaller tube, but you can pass air beyond where they're at, or where the obstruction is. So downsizing is important. If the McGills don't go well, you can't intubate. You've got a kid that's got a super bounce ball that is just sitting there blocking their entire airway. Yes, I've seen that. It's not fun for anybody. Consider cricothyrotomy needle as a last resort. If your protocol says don't do it, don't do it. If you've never done it at all, don't do it. Just lights and sirens and get to us as quickly as you can. And if you're going to be doing that, getting in touch with medical command is really important, because we need to know that's coming. So same idea for needle cricothyrotomy in children's as an adult. And again, it's only when you can, your last resort. You cannot get airway any other way. So procedure, two-handed. You're going to take your non-dominant hand, thumb, and third finger to find your landmarks, using your index finger to figure out where you need to be. Your right hand has your syringe in it. It's going to have your needle on the end, and you need fluid in it. You're angling your needle caudally, so towards the feet at a 45-degree angle, and you'll know you're in the right spot because bubbles come back at you. Again, have practice in a lab before you ever consider doing this on a real patient. And this is emergency only. All right. The other thing to remember in all patients that you've had to do a needle cric on, you can only oxygenate through that. You cannot ventilate. All right. So that means you can put all the oxygen you want in, but they're not going to be exhaling their CO2 through that. So 30 to 45 minutes is about the longest anybody can survive with a needle cric. And so that's, you gotta get someplace that can go for a more definitive airway quickly. Yes, sir.
So that is preferred to a needle cric or use like a quick cric?
So needle cric in kids because of the sizes of their trachea.
Okay.
Yeah.
I mean, I know they make one for adults and they make a smaller one, but we're talking kids, just needle cric.
Needle cric is gonna, yeah, it's gonna be better. It's gonna be safer. Even the small tracheostomy kits may still be too big for the youngest of patients. And those that are at the highest risk for foreign body aspiration are the people with the littlest airways. So we may really, really cause some damage, both you and I, if we try and put a tracheostomy tube in an infant. Adult ENTs are hesitant to do it. They usually want the peds people to do it because it's such a small and there's such a narrow room for error.
With epiglottitis,
yes.
Epiglottis falls over. How hard is it to get back up? Do we grab that with the McGill forceps, or do we want to start?
So,
For the needle?
So epiglottitis, it's a loaded question, and I will tell you now. Let's see, this is 5 years in practice and 6 years, so 11 years into pediatrics. I have not seen a case of epiglottitis yet, though it could be on the return. And so I'm not an expert in saying it's kind of a damned if you do, damned if you don't with them. Epiglottitis, one of the things you want to do is try and stay out of the back of the airway because you don't want anything to spasm while you're there, which the McGills could do. But the cricothyrotomy needle is a higher risk procedure. So I think if you're going to go either way, you get on medical command. Cover yourself and say, this kid's looking bad, this is epiglottitis, which way do you think I should go? Make a decision with someone else. You had one?
What's going to be the definitive airway in the hospital after a needle cric?
So usually after needle cric, so we're going to hope that we have enough time that we can still jet insufflate them a little bit longer, and then potentially we've got more toys like scopes that we can get that foreign body out. But tracheostomy would be the ultimate. But doing that in the controlled setting of my trauma bay, where I at least have the OR resources and multiple hands, is better than doing that in the back of a truck or on scene. In the back, and then you'll be next.
How do you see this practically? You know, the ball stuck in there, nothing going in or out.
Yeah.
The needle in there. How are you attaching oxygen and moving it? And
Yeah, so sorry, I got distracted and didn't go to the end. So once you get bubbles, you know you're in the right place. So you're gonna to take the syringe off the end. A lot of the needles you can rig to one of the end pieces from your ET tube from one of the small tubes. You can actually get to fit there and then hook that into your oxygen source.
I was just going to say, because we don't carry jump. So.
Yeah, no.
and without oxygenating, without ventilating, what does that look like for us? You know, on the way in, what do we do?
So what you're doing on the way in, you're going to connect that to your bag, and you're just going to bag through it for chest rise, and if so, and go lights and sirens. Sorry, and then ventilation. It doesn't mean that none of the air is going to escape out, but it's not going to be effective release of air. So you may not bag at the same rate you would. You might want to go a little slower and let a little more time for recovery. You can also have a partner try and help to, if you're seeing that chest continuing to expand, you can give it a little squeeze and shake, which can help kind of force some of that air up. You can disconnect for a second and see if you can get some of it to come back out of the needle.
Surgical cric contraindicated?
Again, it's one of those things that we very rarely recommend doing in kids in the field, because their airways are so small and they're much harder to deal with than an adult. And then anatomically on the far end, the damage done in the field can be harder to recorrect on the kid once they get there. So this is again the very last resort thing. I'm not saying, hey, everybody, this weekend let's go out and cric people with a needle. But of the three, we'll say surgical airways in the neck, this is the preferred one in pediatrics.
Are we making you nervous yet?
No.
It's really excited to cric people.
So here's the thing: is that you guys are are like young and excited and like ready to get into this. So you guys are easier to wrangle. I also lecture and have done in-service to the guys that have been doing this longer than me. They're the ones that make me nervous because I can't keep them in control when everybody's got a story they need to tell. And so I spend that whole lecture basically herding cats. Like, all right, great. let's get back. We've still got 20 more slides to go. All right. So endotracheal intubation. This is the one advanced airway that we actually have you guys do more than doing a needle cric. So this is where we are directly visualizing that lower portion of the airway, and it is the most effective way to control the airway. So remember, in the infants and small children, it is a very anterior airway. And so you're going to need to use that straight blade because all those soft tissues are different. They're floppier. You want to get past the epiglottis and pick everything up out of the way to get your view. And you're probably going to need someone to eat still yet to push and give you some cricoid pressure to bring things back into view. As kids get older, their airways get bigger, their cartilage matures, they get more like adults. Feel free to use your curved blade, what you're used to. Get it into the vallecula and pull things out of the way. So here, just a quick picture of the little one with a straight blade. We're going past that epiglottis and we're picking everything up out of the way. All right, so proper size tubing is important. This is Goldilocks and the Three Little Bears. It's got to be just right. If it's too big, it won't pass, or you will do damage to the structures on your way in and lead to a lot of soft tissue swelling. If it is too small, it will leak and you will not get appropriate ventilation. So to figure out the size that you need, your equation is age plus 16 divided by 4. For those of you that are math buffs in the room, age over 4 plus 4 also works. So if you have a 4-year-old, what size ET tube are you pulling? 5.
Yeah.
Yep. I love the confidence you went with. You're like, 4. Wait.
I don't want to raise with all 5 hands and let you know that.
Oh, that you thought that I might just I was needing to call on you. I gotcha. I see where you're at. All right.
Do you use like whole like pinky size or size of a
So I've never been pre-hospital. I've never actually looked at that to compare. From intern year on, this formula has been browbeat into my head. So I've never like looked back. I probably should to see if that actually works. Yeah.
Well, I know little kid this morning.
Yeah.
He's obviously 9 years old. He's well beyond
Yeah.
that size, or well below that size. So
Yeah.
is there a weight base or something?
So that, yeah, you're going to have to also use your clinical judgment with it. So I'd say sort of the easier way to do that, you meet a 9-year-old who looks like a 3-year-old in terms of size, put 3 in the formula.
Okay.
If they're a normal healthy kid, put 9 in the formula.
Okay.
Yeah, that's going to be your best way to do it. All right. So cuffed versus uncuffed. This is a big debate that rages on. Most trucks just have one or the other. So I say pick the one you have. In the grand scheme of things, I am in the camp of pro cuffed tubes, but because I don't necessarily have to inflate that. So I have the option of a quasi-uncuffed tube or a cuffed tube versus an uncuffed that I might have to replace if I need a cuff. That being said, that's usually more of a hospital debate than a truck debate, because I know many of you are like, you're like, I have what I have, and I have one size pediatric mask, 2 sizes of the oral airway, and that's it. So with your tubes, use what you have. So when are we going to do that? We're going to intubate when we think there's going to be a prolonged need for artificial ventilation. So you went to the house fire and you see this kid that's burnt everywhere, and you're thinking they're going to be in the burn center for a really long time. There's the guy. The one that you can't bag, you are doing everything you're supposed to. You've got a good seal, you've got a good fit, you've got good position, you've got good technique, and you either aren't getting chest rise or you're getting chest rise and you're just not getting the results that you want. That's the one to go with. Cardiac arrest, respiratory arrest, and then same as adults, the ones that are unconscious, no cough, no gag reflex, those are the ones that have the altered mental status that need their airway protected. Remember, that's a way you can administer medications. So you arrive on scene of a code, you realize we didn't restock the IOs, we've tried 3 IVs, it's not gone, but we were able to get an airway. You can put your epinephrine down the ET tube. That should be on your Broslow card of your dosing there. It's also a way to gain access for suctioning. So the chronic kid that is just copious mucus everywhere, you can feed one of the thin catheters down it and suction below if you need. And then those that you, like say, the inhalation injury, the ones that you are really worried about their airway worsening or some sort of edema situation, that's the one to consider it in. The crooper that's sitting up and just noisy, not necessarily, but the one that's already drooling and tripoding, that you're going, is this crooper, is this epiglottitis? You may have a better shot at that point. Again, watching for chest rise and fall is still our gold standard for ventilation. We want to listen after we place the ET tube to make sure we're in a good spot. It's really easy to go right main stim on kids because everything's smaller and your adrenaline is pumping. So listen for equal breath sounds, apply capnography, make sure you're getting things, getting return to show. And then if you have a cuff tube, go ahead and inflate that with the recommended amount of air. So we're going to ventilate them with 100% oxygen. We're going to make sure that tube is secured, and then you guys are getting to me, and you're going to let me know as soon as you can, hey, I've got an intubated patient coming. Because on my end, that means I can get my respiratory therapist and a ventilator downstairs to help me out, so I'm not managing the airway that you've already managed. I've got somebody to do that, and I can work on the rest of what's going on with the kid. So always verify your tube placement. The reason we keep saying this is a very high risk situation for pre-hospital intubation in a kid. That's one of the high litigation things. If things go bad, they go, it's, well, that medic didn't get the tube in the right place. In your documentation, I visualized the tube passing through the cords. Immediately after intubation, we auscultated breath sounds bilaterally. We saw good chest rise. Capnography was applied. If you have a color changer, with good color change. If you have the monitor with a good pleth and an initial CO2 of. You're saying, I saw it, I saw it, I saw it, and everything that we know without being able to take an x-ray in the back of that rig said it was in the right place. All right, so you did an excellent job. You've got the kid intubated, reloaded, and now you're driving to me, but you're coming from Deer Park, so it's a long way in. And you make it to North Division, and now suddenly all goes wrong, and we're not getting SATs anymore, and we're not getting waveform or capnography. Something has happened. You're dope pneumotic. Is it dislodged? Look and see, is that tube taped at the same place it was? Or did you, while you were hooking up the IV fluid, it caught on your sleeve and now it's out? Is there obstruction? If this is a mucousy kid, that mucus can have occluded the tube as well. Pneumothorax, listen to both sides. Or were we aggressive when we were bagging, or if you're running on a truck with a ventilator, did we set the settings too high? And now we've got one lung that's working and one lung that's down. Or equipment failure. If you're on the vent, probably one of the first things you should do is take them off and say, maybe that's the machine's fault. Let me see if I can bag and make us into a better place. And then, check your oxygen tubing. Yes, I'm bagging, but there's no longer oxygen flowing into my equipment. All right. As I mentioned, ET tube placement is very high risk for malpractice in the EMS world. So document, and then if you think you've written enough, document some more. Unfortunately, that's the world that we live in now, that if you didn't write it down, it didn't happen. All right, RSI, so Advanced Airway Management, you're going to need to know what your local medical command lets you have. And a lot of places, paralytics, for whatever reason, are on the list of meds you need to have permission to use. But in the kid that is in severe respiratory distress, but not yet failure, so they're not unconscious and loose, you may need a paralytic to get where you need to go to be able to secure an airway before you get to true failure. So succinylcholine is used a lot of times in the pre-hospital setting and as well on the adult ED. And so I use a lot more rocuronium because my kids are a little higher risk. if your kid has a neuromuscular disorder, don't use succinylcholine. It can precipitate them being paralyzed for a really, 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 really long time because they don't have the receptors that are working and functional. They may be slowed, so it's just going to sit there for an extended period of time. Those with muscular dystrophy are at risk for having a reaction where they get hyperkalemic from succinylcholine, so that's not a good group to use it in. And then remember when you are picking up a patient from dialysis, hyperkalemia is also a contraindication because other patients, not just my neuromuscular disorder kids, can have it. So if the old man they're calling you, or even my kid, is hyper-K at dialysis and you give them succinylcholine, you can drive that up even further. None of us like wide complex tachycardia and don't really want to be the cause of it. All right. You want to give a sedative agent for all kids that are alert. If they're unconscious, you don't have to do that. So extraglottic strategies, not every truck comes with LMAs, but they are great. LMAs, if you haven't seen one, basically just slide into the posterior pharynx and sit just where they say in the larynx, and provide a seal around the edge, and we'll let you be able to ventilate patients. They are pretty easy to insert, so that makes them really useful. Okay, getting into types of shock. So cardiogenic shock and non-cardiogenic shock is how we break these down. Cardiogenic are the ones where there is an impaired ability of the heart to maintain the cardiac output. This is the rarer one in kids like we were talking about, but it is also the one that is really ominous and often fatal. Non-cardiogenic shock, hypovolemic, obstructive, distributive shock, and of those, hypovolemic is the most common one you're going to see in kids. So hypovolemic shock, this is where we're looking at the dehydrated kid. They've lost their intravascular fluid. They may have a history of vomiting and diarrhea. They may have blood loss from trauma. Remember, burns can get there too. If you don't have a protective layer of outer skin, then you're going to lose much more water in an evaporative manner. So we're looking for them to have signs of dehydration, just like we were before. Decreased mental status. We're looking at their delayed cap refill, their tachycardic, their tachypnic. They're not having tears. Their fontanelle can be sunken. Their skin turgor can be bad. That's where when you feel their skin, it looks like you're making cookies and you didn't put enough water in the dough, and it just kind of sticks and molds when you touch it, rather than nice normal skin that has play and that you squeeze it and it pops right back, more like your fingerprints want to stay in that skin. The other one is sudden weight loss. If you weigh 10 kilos and now you weigh 8 kilos, you've lost 20% of your body weight. So that's a sign that you're dehydrated. Parents will say things like their clothes aren't fitting right. These pants used to fit, now there's a lot of play to them. Their belly will look like sunken in, pretty scaphoid. So those are all sort of things you can look for. With them, so first answer in shock, apply oxygen. Get your IV going, and then we're going to start with our fluid resuscitation. With our kids, we do 20 mLs per kilo boluses. Lactated ringers, normal saline, whichever one you have on the truck, fine by me. I want volume in that kid. Give a bolus, recheck. If you're still shocky, give a bolus, recheck. And some of these kids will need 80 to 100 milliliters per kilogram to replete their fluid. So that would be 4 or 5 rounds of boluses to get their volume back to a good place. Distributive shock, usually this is what we're going to see with infectious processes. This is where you have your normal blood volume, so you're not dehydrated, but now for whatever reason your blood vessels are dilated, so it's pooling where it doesn't belong. With them, these kids are going to look pretty ill appearing. We're going to look at the sort of for those same signs of shock. Anybody guess what this kid has? Anybody know that? Name that bacteria? That's meningococcemia. So this kid, there's a reason that that they're now trying to get all teenagers and those that live in institutions meningococcal meningitis vaccines. It is rapidly progressing. It leads to shock very quickly. All of this is bruising and bleeding into the skin because the blood vessels are so leaky, they just don't hold anything out. So he's just bled all into his skin. It can happen quickly. It is aggressive. Blood cultures, the few cases I've seen are usually positive 4 to 6 hours after we send them down, rather than the usual like 24 to 36 hours it usually takes to grow a bacteria. They are very, very, very sick. Okay, so getting oxygen, IV, start our boluses. With them, remember, this is a problem where the blood vessels are dilated. So you may need to get some pressors on board with them to constrict those blood vessels so you can get some return. If you don't have a protocol standing to do that, early on, get online with your medical command and say, I've got a kid that looks shocking. If you see this kid, I'm worried about meningococcus. The definitive treatment for them is antibiotics, so they need my place quicker than yours, but you can do a lot to help them get into a better place by being aggressive early. Yes, sir.
In the PTR, what type of pressors do you guys use?
So dopamine is where we often start with them, because for us it's a little bit easier. It's usually a quickly accessed medicine. There's a wide variety of things that it's good for, so there's less contraindications for it. And with dopamine, we can even start it kind of on a peripheral IV versus epi that we try and avoid in a peripheral IV because you may get some vasoconstriction there and then get local damage from it. So dopa is kind of a jumping off point, but dopa, epi, norepi are the big ones that we use. The unit adds a lot more once they've had a chance to get their teeth into the kid and know more specifically what's going wrong.
How's the dopamine dose compared to adults?
So tell me how dopamine's dosed in adults, because
the kids dose it. That's 20 for
So dopa, it's per kilo dosing, and now that you said it, it has slid out of my head, but it should be on your PALS card. I'll look it up and let you know. All right. And probably, like the Bradlow tape should have it as well.
I think that's because, like, I think we hear a lot of sleep with that as adults.
Yeah.
Is that because kids' hearts are fairly strong, they don't care that this cardiac stuff
Yeah. Yes is the simple answer. Yeah. So anaphylaxis is the next one. So this is another one of those distributive shock situations. This is where we're going to have a lot of vasodilation. This one, instead of leaking blood into the skin, we've leaked fluid, so that's what's leading to all that edema. With them, you can still get into anaphylactic shock. This is the place where epi is useful. Remember, anaphylaxis is multi-system. So angioedema, facial swelling, wheezing, urticaria, vomiting, diarrhea, altered mental status, they're feeling anxious, feeling my throat's closing in, hypotension, all those things are signs of anaphylaxis. So mild allergic reactions. I have some hives. I'm a little itchy. My eyes are a little puffy. You know, simple things, but the kid is running around, normal vital signs, otherwise looks okay. Benadryl. Anaphylaxis, multi-system involvement or any kind of decreased mental status. Benadryl, O2, epi. And we're going to do that 0.01 milligram per kilogram IM, maxing out at your adult dose of 0.3 milligrams. All right, and then with severe anaphylaxis, then we're going to do our epi, and then we're going to add IV fluids at least once. And if they're still in a bad place, you can consider doing the cardiac epi IV. So remember, the IM is the less concentrated, the 1 to 1,000 version. Your IV is your 1 to 10,000 version. So it's the same 0.01 milligram per kilogram, maxing at 0.3 for them, but it's a different concentration. And then if they're wheezing, I don't know, it says small, but albuterol is a consideration. All right. Neurogenic shock also is a distributive shock. So that one is we've damaged the parasympathetic and sympathetic changes, and so now we're no longer getting feedback to control our vessels. And so with them, you're gonna again pull distally. If you're worried about their blood pressure, if you're worried about shock with them, get online early. You're probably going to need to give them suppressors to get response because their body's not going to be able to respond itself. Cardiogenic shock. So inadequate cardiac output. Again, this is our rare one. And most people think cardiac disease or our congenital heart disease. They're actually the more rare ones that have cardiogenic shock. It's more toxic ingestion and drowning events that are having the cardiogenic shock outputs. So that you're going to see arrhythmias with these. You can be tachycardic or you can be bradycardic. If you are tachycardic, you are revving up and going fast. You do not have a chance to fill that ventricle before you beat again, and so low output for that reason. In the bradyarrhythmias, it's just too slow. So I'm filling up the balloon, but I'm not pumping it frequently enough to get things out. You need to be judicious with fluids, just like the CFer who is bubbling and frothing at you, and you're putting the BiPAP or CPAP on to oxygenate him. Giving him a liter of fluid's probably going to make things worse. Cardiogenic shock is is the same. So start with small volumes, 5 to 10 mLs per kilo of fluid with them, doing it over 10 to 20 minutes, and reassess before you give more. If they are now crackly after fluids, another bolus is probably not a good idea. If their liver is now palpable way down below, probably not a good idea. If you give a bolus and they look puffy, probably not a good idea to repeat. All right, so in general, if you suspect shock for any of these things, provide oxygen via face mask if you can, 100% O's. You're going to get vascular access if you can't. I'm okay with an IO if you're not being able to get your IV in place. Begin your fluid resuscitation. Remember, 20 per kilo per bolus for the first 3 types of shock. Cardiogenic, we're doing a smaller volume. Check their glucose, get them transported, get them comfortable, keep them warm. And then if you can figure out, if you see what their underlying is, then try and correct that problem while giving fluids and oxygen. All right, so moving into specific things you're going to see. Croup is one of the most common things that you're going to get called for. It's going to be your late night, early morning calls. They were fine when we put them to bed, and now they're not anymore. They're in respiratory distress. Croup is an upper airway sound, so it makes stridor inhalation. It comes with a very distinctive cough. It's a barking seal cough. It's an adult version. Kids are a little more seal than me. I'm sorry, my airway's so big. Yes, if you get to shadow me, you will get the whole cough lecture. Yeah, we can do that. So edema is in the glottis and in the larynx. It happens quickly. 6 months to 3 years of age is your most common group to get croup. Like I said, it's the harsh, brassy cough. Don't go examining their oropharynx with a tongue blade. Let them open their mouth, look in there, see what you can see. But stressing them out makes them worse, and tongue blades tend to make them worse. They can get kind of restless. They can get tachycardic. They can get cyanotic if they're not getting enough air in. So start with oxygen, cool mist, or just O2 by a face mask. If they are freaking out because you put the mask in their face, figure out one of those blow-by techniques. With the racemic epi is your treatment of choice. The big kids, those over 2, it's a 0.5 ml dose diluted in 3 mLs of saline. For the little people, it's half dose of 0.25 mLs for 3 mLs, in 3 mLs of normal saline. With this group, keeping them calm is important. The more you stress them out, the more distressed they get. So you don't want to do anything that's non-essential to them. This is not the kid that you have to get an IV started in. We usually turn them without needing it, even in the emergency department.
If you're suspecting that they're going to be very intolerant,
Mhm.
holding up an SDN over there,
Mhm.
would you dilute less and try to get more of that medication faster?
No, I think you still try and go with your usual amount, because you want to get as much med in as you can, without causing damage by doing it too concentrated.
Okay.
Yep. All right, epiglottitis is the one we talked about. I haven't seen yet, but maybe coming back to us. It's going to seem kind of like croup. It's going to be swelling in a similar port in the airway. Instead of viral, this one's going to be bacterial. They still are going to have kind of a change to their cough. They're still going to have stridor, but they are going to look really sick. With these, the age range changes on them. This is older kids typically, so 3 to 8 rather than our 6 months to 3 years. Typically, they're, in addition to all that noise when they cough, they're going to be bringing up pus or mucus, and they typically have a pretty high fever and they look sick. So like the croupers, you can try your racemic to see if you can reduce some of that airway swelling, and get them on high dose oxygen. Again, I wouldn't anger them by trying to get an IV in. I can do that when we've gotten their airway in a little less tenuous position. Foreign body aspiration, we talked about this a little bit earlier. So if it's complete, we're not going to have much in the way of air movement. If it's partial, then stridor, muffled voice, hoarse crying, drooling, all sort of things that we can see. If it's a partial obstruction, but they're not in distress, humidified oxygen and let it go. If it's a complete obstruction, go through the techniques we talked about earlier. Again, finger sweeping in the mouth only if you see what you're aiming for. We've gone through all of that. We've gone through that. We got onto cricothyrotomy for a little while. All right, asthma. Another one, you're going to see chronic inflammation of the lower airway, and asthma kills kids. So aggressive treatment early is important. So it's a 2-part process. It is bronchospasm. My small airways are constricting, and I'm making mucus and the lining is getting really inflamed. So it's a 2-part process that we've got to fix both parts. So their cough is going to be different. Here's your next one. They have a tight cough. It's an exhalation problem. That's why when you're listening to wheeze, you're hearing that as they exhale at the beginning, and then it progresses. Their cough is tight. They can't get air out. It often has like a breathy, almost wheezy sound at the end of it, as they can't get a good force of air up and out of their lungs. So they're most likely going to respond to bronchodilators. I'm going to give them steroids. Some trucks are now putting policies on board that you can even give steroids in the field. I don't know where that is here at this point. So if they are untreated, hypoxemia will continue to worsen. Your level of consciousness will go down. They will typically retain CO2 because remember, we can't breathe air out, so they will get combative before they go all the way out. So inhaled nebulized bronchodilators are your treatments of choice, 2.5 milligrams diluted in 3 ml solution, and give that by your SVN. Some trucks will be carrying ipratropium, so you can make your own duo-neb for them. You can remember that I will give 25 milligrams continuously over an hour for up to a day to treat them. So if you do 2.5 and they're still terrible, repeat it. All right. Signs that they are struggling: sitting forward, leaning to Kipnick, that unproductive cough. Audible wheezing is a bad sign, and no wheeze at all in respiratory distress, really bad sign. So when you are an asthmatic and you start to spasm, the first thing you do is get wheeze at the end. So inhale, exhale, and a little ee right at the end. It progresses. Now I'm going to have a full expiratory wheeze. So inhale and ee the whole way out. Then I'm going to wheeze in both directions. Ee, 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 ee. And then I'm going to get so tight I can't make sound anymore except a pop or a squeak. So you don't hear any air and just an occasional and they're working like crazy. That's a sign that you're in a very bad place. Be aggressive with them. All right. Status asthmaticus is those prolonged attacks that are going to need aggressive therapy. They're going to need me and you working together. They are a medical emergency. These kids end up in the ICU to get their asthma under control frequently. Yes, sir.
How do you feel about MAG and asthma for children?
I love MAG. Depending on who you talk to, 50 mg per kg or 75 mg per kg, maxing at 2 grams given over 20 minutes.
What's your dose for kids then?
So depends on where I work. In fellow, 50.
50, all right.
Yeah. Yeah. So I haven't been told I can't use 75 here, but all through fellowship I used 75. My last wouldn't let us go over 50. And we had to beg pharmacy to let us give it over 20 minutes.
Up to 2 grams.
Yep, up to 2 grams. For asthma, I love IM Epi. I love Epi drips. I love tropidutylene drips. I love BiPAP for asthma. I love anything but intubation for asthma. Asthma, you can't exhale. I'm not making you guys breath stack again, but if you intubate an asthmatic, you are breath stacking for them, so it gets uncomfortable in a hurry. Bronchiolitis, you will see a ton of this. We are still seeing a ton of this. Bronchioles, lower airways become mucus factories. Suction, 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 and then suction some more and get that crap up and out as best you can. They may be wheezy. If you do a neb with them and you get no improvement, doing another's probably not going to help you out. Much, much, much less responsive to albuterol use than asthma, okay? Because it's not a problem of bronchospasm, which albuterol treats. It relaxes those airways. This is mucus sitting in the way. So give them supplemental oxygen with them. You can, like I say, you can trial that albuterol, but sucking them out is the best way to go. Not really. I mean, potentially, and I've seen some pulmonologists and the really bad ones that use a little bit of inhaled Atrovent, but there's no great data that says it's going to be super effective. The annoying thing about bronchiolitis is basically everything we come up with that we think that's going to be the thing that fixes it. We try it for a little while, we do a big study, and we go, nope, it's the same. The same outcome or worse than if we just suck them out and provide oxygen and support. So seizures, neurologic emergencies, they can happen from head trauma, hypoglycemia, ingestions, tumor, CNS things. So partial seizures are the ones where it's not full body. Tics, jerking of a single portion of the body. Generalized seizures, you guys have probably seen those tonic-clonic movement of upper and lower extremities, loss of consciousness. Just remember, in infants, they are not wired up yet. They are still developing a neurologic system. So they may or may not have full body shaking and still be seizing. So if the 6-year-old's giving you the stink eye the entire trip, or 6-month-old is giving you the stink eye the entire trip and hasn't moved, hasn't blinked, and is just staring at you as I'm making you quite uncomfortable doing it, that may actually just be his sign that he's seizing, that he's just got his eyes fixed in a single patient place. They can just blink at you. They can lip smack at you. They're a little bit different. So status epilepticus, that's when we have a prolonged seizure longer than 20 minutes or multiple seizures without returning to baseline in between. And those are worse than just your generalized single seizures because we're often not oxygenating properly. And so those are the ones where you can get end-organ damage, especially damage to the brain tissues from lack of oxygen. Febrile seizures are what you guys are going to see probably most frequently in kids. It's the #1 cause of seizure in children. It's related to as the temperature spikes up, there's a big dump of cytokines into the system and it overwhelms and they seize. parents will be absolutely freaked out and they think their kid has died. So just keep that in mind. You're going to be doing a lot of de-escalating of the situation. So any pediatric patient that is persistently seizing needs to come to the hospital. Sort of extra things that you can figure out on the way that may help me out. Is there fever? Is there not? Do they have a history? If they have a history, what's worked well with them? Remember, if they're actively seizing and they're a kid with a seizure disorder, if parents say, yeah, Ativan is part of our daily routine, they're probably going to need more benzo than the average bear that's used to, or that's naive to it, to break seizures. So with them, try and get an IV if you can, normal saline bolus, check a glucometer sugar, and these kids can be low, and then administer diazepam or lorazepam depending on what your local company allows you. It can go rectally, it can go IM, it can go IV. Orally is probably the only option you don't really want to go with, and some places are even starting to do intranasal Versed for this situation. Meningitis, we kind of went over earlier. We've talked about vomiting and diarrhea and fluids in our other situations. I'm just trying to get through so you guys can get out of here close to on time. Hypoglycemia, with them, the thing to remember is that the glucose that you can give to adults, you can't give to little people. D50 is sclerotic to their veins, and so you need a diluted concentration. The other reason to not do D50 in the little guys, their pancreases don't respond well to giant boluses. So if you smack them with an amp of D50, their pancreas goes, oh, we just ate, I need to dump out a bunch of insulin, and then you may end up with rebound hypoglycemia in them. So using a less concentrated glucose works much better in them. Yes, sir. So D10 is what I typically use for the little guys. 2 to 4 mLs per kilo is where I go. And if you have a truck that only carries D50, half of it out, pull up saline, now you have D25, half of it out, like, you know, shake it, half of it out, pull it up, now you have D12.5, that's close enough to D10. Okay? Yeah, it gets you a less concentrated glucose, yeah, without you guys, you know, having a ton of things on the truck. Remember, diabetic kids are at risk for hypoglycemia, as are those kids that are ingesting parents' medicine. So ask if there's diabetic meds in the family. Hyperglycemia, that's typically, we're going to see that in terms of DKA. Left untreated, this deteriorates really rapidly onto coma. In the pre-hospital setting, IV fluids can start to drive down that glucose.
The same kind of levels as an adult.
Yes.
Like,
Yep.
you get scared when things
Yep.
don't read.
Yep. You get scared when things don't read. Now, like my insulin-dependent diabetics will often tolerate it a little bit better, but if your glucometer is not reading, it's a pretty bad sign. All right. Remember, with hyperglycemia, there's probably going to be dehydration with it. The kidneys are seeing that huge amount of glucose and just making pee. And so with them, getting fluids on board will help, 1, dilute the sugar, and 2, replace what they've lost. All right. Poisoning and toxic exposures. These are usually the little ones and then the teenagers that are doing this intentionally. With them, use your ALS, BLS skills with them. Remember, poison control is always an option to you, to me, to anybody. 1-800-222-1222 is a number to just have committed to your head, because they can help you out if you get on scene and you don't really know what to do. With them, administer oxygen. It's not going to be a bad thing to help them out. Touch base with your medical command if you can't remember what that number is for the poison center. Activated charcoal is a hot button topic in the poison community. Some areas love it, some areas hate it. Figure out what you want. I have only seen it given twice here, but I've only been here for 6 months. We loved it in Pennsylvania. We hated it in Tennessee. So learn what your local group likes. Remembering that charcoal is an aspiration risk, and in the unconscious patient, and charcoal into the lungs is worse for them, it gives an aspiration pneumonitis that's really hard to treat. So if they're actively vomiting, it's probably better to just let them puke it out than to try and put charcoal in to absorb anything.
Have you seen any Tide Pod patients?
I haven't seen Tide Pod patients here. I've seen Tide Pod toddlers plenty, because they look like candy. And then, and then our teenagers are not bright people, and so Tide Pod challenges are terrible, terrible things, and hopefully that just goes away. With them, if they're unconscious, if they're unresponsive, administer oxygen, prepare to ventilate them as needed. You may need to intubate them. All right, I think 1 o'clock was the end time. I'm gonna stop here rather than try and do trauma for you guys in like a 5 minutes that I'm keeping you guys over anyway, unless anybody is dying to get through that portion.
Is there a nutshell of trauma?
ABCs.
Can we go over that?
So remember, kids are not just little adults there. So their patterns of injuries are going to be different. They're much more spongy and flexible. So they, like we said earlier, they get the viscous organ injury. They get the lung injuries, the pulmonary contusions, those sorts of things, more than adults. They do stupid things that they shouldn't because either they don't know better or because they've been dared to do it. And so they can hurt themselves pretty easily. On scene, ABCs, or, as we joke about it, ABCs, but that's your most important thing. Watching for signs of shock with them, especially if you've got bruising over the belly, because if they've got multiple organs that are bleeding in there, they can get hypovolemic pretty quick. So getting your IV in and repleting their fluids is important. And then they get a lot more long bone injuries than adults. So stabilizing those is important. As far as spinal injuries and neck injuries, immobilization is always kind of the big question of how do I do this in a kid, because you're not going to have a whole lot of options in terms of C-collars, and they may or may not fit. I've seen a lot of really ingenious medics and EMTs that get really creative, making sort of neck rolls out of towels and tape and pinning heads down in that way, rather than putting an ill-fitting collar on that the kid can just swing from side to side in, or it fits in such a way that's going to be up in their face, including their airway.
In regards to the hypovolemic shock,
Yeah.
we always talk about it trying to maintain a systolic blood pressure of about 90 in adults. Is there a golden number in kids?
So your minimal acceptable, let's say it's a moving target based on their age. 70 plus 2 times the age is the lowest acceptable. So you want to aim for somewhere a little bit over that, with the teenagers approaching your goals of adulthood. Other questions, concerns? You hated it, you loved it. I can never come back, I don't care. So it's a lot. It really is a lot to get through. But like I say, I think at this point, I've had you guys for 3 hours. I've dumped Pete's knowledge on you guys over and over again. I don't want to keep belaboring the points and knowing that this trauma stuff you're going to go over in the future. So, all right. All right. This is the world's worst mouse.
I'm gonna go eat.
After tight budget, we're back at 22. Thanks again. Once you come next door, let me get you some paperwork filled out for an honorarium.
Oh, okay.
Remember that?
I hit pause on that.
No problem. I got that.
Yes, sir.
Yeah. Is it still gonna just stay as a?
We don't know what it is.
Yes, SIDS is one of those tough things that, it's hard because on the hot seat, there's not a lot that says what it is. So kind of, it's like bronchitis, so it's like everything we think turns out to not be right. So